This is Transqat. What is Transqat? Transqat is a safe space. It's a place for respectful conversations about transgender issues. It's a place for queer people to come tell their stories. I'm host Clare McCarthy. Welcome to Transqat.
Amanda Kayte, she was like, "Can I bring coffee?" And I was like, "You better, because I'm definitely bringing coffee."
I went for the
Cumbies.
I love Cumbies.
Please give me the bucket of decaf.
Yes.
What is this little kitty?
Oh, I love the cats.
I'm obsessed with cats. You're in good cat company.
Now, is that a particular...
It's like just a little sleeve. It's called
that from
Baxendale & Co. And this is a Starbucks lavender latte because I'm still riding high on my new Taylor Swift album.
I am the worst queer person ever because I have listened to neither Beyonce's new album nor Taylor Swift's new album. See, you're rolling your eyes at me,
Jolene
Amanda.
is just like, I just would listen to it on repeat.
Yeah.
Like 1,000 times. Your posture's so good.
I'm trying really hard. That's why I go to physical therapy.
Awful.
But you gotta tits to the sky.
Yeah, that's...
All right, Claire. Listen, we're like...
I don't even need to be here. I'm gonna go read, and I'll come back in an hour, and you guys just...
We're actually both like introverts as well. We're both like extroverted introverts.
Right. So in a small, like 3 triangles, really comfortable.
Right.
Bigger one-on-one lines, also comfortable.
Yeah.
I was not prepared for geometry being a part of this.
We're scientists.
Yeah, I'm sorry. I try to be welcoming of all types of people, but
Even science nerds?
math people, no patience for
Well,
you.
you know, I have 6-year-old twins, and they're really into math, and I never learned my multiplication tables. Like, I've been to a million years of school, and I just not good at rote memorization like that. And they'll just be like, "Ema, what's blank plus blank or times blank?" And I'll be like, "Don't ask me that, please. Ask me about God or sex or something like easier than multiplication tables."
You didn't see. I still break into song on the multiplication tables because of Grammar Rock or Schoolhouse Rock. Rather, the 3 is a magic number song is forever ingrained in my
3
head.
is a magic number. I remember that one. Yeah.
3 is a magic number. Yes, it is. It's a magic number.
We only learned about, I only know about football because we did
Taylor
math
Swift?
football. Well, yes.
Okay.
But also we did math football with multiplication cards. And it would be like, you know, you'd have to go against the other team and have to like get your multiplication tables, like, you know, to, I don't know.
Competition.
Yeah. I don't
streak
actually
came
know
up.
that it was football related, but I know that when you got to the end, it was a touchdown and I was like, took it very seriously. So.
That's where my anxiety started. Those timed tables.
Yes,
that
the
would
one-
have like
that they
1
would
minute to
hand-
fill out
Oh, yeah,
like
yeah, yeah.
100 multiplication sheets.
We used to do around the world, and I thought that was the coolest thing. Did you ever?
No,
Oh, okay, so this was back in the days when classrooms were all in rows. Okay.
Are they not now?
No,
Now they're like little
circles?
groups and little pods.
I
and-
once got observed when my class was in rows, and that was in the evaluation. Was still in rows! 2 exclamation points. But so the first kid in the first row stands up, and you ask them a multiplication question. If they get it right, they move. They stand next to the desk behind them, and then
We used to do
whoever
that with
gets that
spelling bee.
right moves on.
That's
and
really
you
fun.
Try to see if you can make it all the way around back to your seat.
To be honest, I'm into that. Like I would learn with that kind of like
Pressure?
Yeah.
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 It's like the
I love a
Socrates
pressure.
method where you just like ask. And then you feel guilty when you fail.
Well, as opposed to OBGYN and midwifery. Midwifery?
I think it's midwifery.
Midwifery.
Yep.
Okay, let's get it right. Where there's really no stress involved.
Not at all.
There's
zero.
Yeah, it's kind of
Yeah. I don't even have to wear deodorant anymore. It's just
I wasn't going to say anything. Oh, my friends.
Okay, focus.
No, but do introduce yourselves.
My name is Amanda Rostkowski. I am a gynecologist. I did a residency in obstetrics and gynecology, and then now I subspecialize in minimally invasive gynecologic surgery, gender-affirming care, and trauma-informed care and pelvic pain. I have a practice in Hamden, Connecticut, where my lovely colleague Amanda Kayte Corcoran works with me there.
So we should prep the audience for the fact that there will be, during this conversation, there will be Amanda and there will be Amanda Kayte.
Correct.
Yes.
And then really the only person who came ready to make distinctions is Clare.
Yeah.
So there's Amanda Kayte, and
right.
then Clare.
Is your middle name Amanda? Or
Oh my
As
gosh.
it turns out, no.
But do you want to hear
I
something?
might change it now if it's going to get me on the in with you guys.
Yeah, when Amanda Kayte joined the practice, we had to come up with a distinction, and her middle name is Kayte. So she
So it's
became
Amanda
Amanda Kayte.
I'm Claire Rebecca.
Oh, I love that. I love
Yeah.
Rebecca.
Thank you.
Well, I'm Amanda Kayte, not Amanda Rebecca. And I am a certified nurse midwife, which is an advanced practice nurse. And I work with the amazing Dr. Rostkowski, Amanda, at Comprehensive Gynecology of Connecticut. And I also specialize in LGBTQIA plus care, trans care, and my love is trauma-informed care.
Now since that term came up for both of us, both of you,
All of us.
Let's all of us. It is though. It is.
It should be.
Yeah.
And something that other guests have brought up is that all healthcare is gender-affirming healthcare. And when you're talking about LGBTQ plus folks, trauma-informed care is a big part of that.
Yeah.
So let's talk a little bit about trauma-informed healthcare.
So trauma-informed care is an older concept that came out of mental health and substance abuse care. And it's the idea that everyone has innately within them some trauma. And our job as healthcare providers is to acknowledge that, they have some trauma and to not make more trauma, to allow them the space to share what they're comfortable with, what they're not. It's about them being involved in their care and really allowing that conversation.
I think that giving space to the patients when they are able to be open with us about their history of trauma and just acknowledging that it happened, whatever it was, whether it was physical, emotional, sexual, and acknowledging that it happened and that it was horrible and it shouldn't have happened, and just letting them know that we're going to take all of that into account. And again, like Amanda Kayte said, every interaction with every patient should be trauma informed, but patients that disclose to us their history of trauma, we even tread even extra carefully.
Yeah. And I let patients know that, and everyone know that we don't get to choose what causes trauma, right? And we don't get to choose what triggers our trauma. And so even if they say, because 9 times out of 10, someone will say, yes, I do have some trauma, but I think I'll be fine. And I always say, okay, well, just so you know, if at any point you are not fine, you are in charge. So you tell me, you let me know, we stop, we pause, we cry, we, abandon ship for today, and that's fine.
What does that look like? Because most of the appointments that I've been to are rigorously scheduled, and there is a lot of pressure for the doctor to get in there, do your thing, move on to the next one. And the good ones, I can always tell that there's a balance between, the how are you today is a legitimate question as opposed to a rhetorical question.
Right.
But you don't have unlimited time to sit and have conversations. So what does that look like when somebody's in the room with you?
That looks like us running behind sometimes. It looks like us being late
Yeah.
for some appointments. It looks like us doing our charting at the end of the day at home.
Yeah. Amanda and I are really famous for texting each other at 10 p.m. while we're still closing charts. So it is a choice. We all have a choice. And it is a choice that we make to know that we're going to use a lot of time and a lot of tissues. And for me, coming from a space where I wasn't really allowed that, where I was not punished, but where I just really could not keep up that rigorous schedule and treat patients the way I wanted to, that was a choice I made. And that was a choice that, I made really clear when I started working with Dr. Rostkowski and she was on board, which is the most amazing thing. So
I think that you do not have the ability to practice a trauma-informed care, and you don't have the ability to really find out what's going on in a person's life as far if you're practicing gender-affirming care and you need to find out about a patient's gender journey. You cannot do that in 10 minutes. You cannot do that in 15 minutes. Our new patient consults are at least 30 minutes and usually 45 minutes. And in that time, we always meet patients when they're completely clothed. Patients do not get undressed until
So I'm
we've
not
had
sitting there in the
Exactly.
Johnny with my butt flapping in the
Exactly.
wind. Right.
Nobody is comfortable in a gown. And we make sure patients are covered. We give them extra sheets and whatnot to make sure that they can be as covered as they are comfortable with. But in any case, we always meet patients when they're clothed, and then they have the ability to get changed. And then we might go see like a quick patient that's just like a medication follow-up and they're doing well, and then we can pop back in. So we try to arrange our schedules in a way that we can deliver the quality care that patients deserve and we know that we can provide.
I had my annual physical last week, and I could tell that things were moving more quickly than warranted any sort of actual responses from me besides, yeah, I'm fine.
Right.
And it just so happened, wasn't a big deal, but it just so happened that the day that I went in, I was feeling pretty down, and they started to ask. I just made the decision. You know what? I don't have the time, and you don't. Clearly, you don't have the time. So I said, no, I'm feeling a little off today, but I'm fine. Let's just. And I would have liked to be able to say, yeah, well, here's what's going on, and it's not a huge deal, but it's really got me down today.
Yeah.
And then everything that followed from that would have been a little bit different, I think.
I think it's important to acknowledge there are so many hours in the day, and we cannot spend 90 minutes with 20 patients. It's just not possible. But we can make choices. Like Amanda Kayte said, like today, if you're here for an annual exam, a preventative health visit, that's really scheduled for the shortest amount of time because really that's, let's make sure your screening is up to date. Let's make sure your blood pressure is okay. And then if there's an issue, we're going to need to devote more time to that. And we want to devote more time to that. Yeah. So we might have to have you come back another day. And that's just the reality of life. You can't do 90 minutes of work in 10 minutes. It's just not possible.
And I find that most patients like really appreciate that when we kind of say like, hey, so I know you were scheduled for an annual today, but it seems like you've got a lot going on with, X and Y. And so why don't we focus on that and let's have you follow up in, 2 weeks or 3 weeks. And sometimes people are disappointed, but I think for the most part, people appreciate that. And, as you're talking about your feeling kind of down going into your visit. I mean, every single patient we do, a mood score, a depression screen on. And I've had a patient say to me, well, why am I even doing this? Because you're not going to do anything. And I said, well, we actually can help you. Like there's things we can do. There's people we can refer you to. There's medications. Like we have a plan if you need help. So that's why we ask, because we do actually want to know if you're okay.
There's a rhythm to every conversation, particularly when it's one-on-one.
Yeah.
And I can hear when that breaks.
Yeah.
I can hear when it's no longer a question that was, this is what you're supposed to ask and this is how you proceed for that 10-minute block of time. I can tell when the rhythm breaks and somebody is actually asking me, you okay?
Yeah.
Yeah.
And there are techniques, right? You can ask someone if you can ask.
Yeah.
You're looking a little down today. Do you mind if I ask you about that?
100%.
And it changes the rhythm of the conversation. Right. And so that signals to me, oh, I'm in a safe place.
Yeah.
I'm in a place where somebody actually cares whether I'm down today.
Yeah.
When we're talking about queer folks, when we're talking about LGBTQ folks in your practice, what does trauma look like? What forms does that take? What do you have to be careful of?
Yeah. Well, I mean, I think it's super complex, right? There's not like a clear cut anything. So sometimes, especially in the last couple of years, we've seen a lot of patients moving to the area. Maybe they've moved from other parts of the country where they're kind of seeking like a safe space for care.
Connecticut is an asylum state for trans rights.
So I think we've seen a decent amount of patients coming here for gender-affirming care and just to feel safer. And so I think there can be a lot of complex trauma, familial trauma, unfortunately, a lot of sexual trauma. I mean, I think we see that across the board. We do particularly see people with pelvic organs, right? So we typically see people that are assumed female at birth. And those people, again, typically have higher rates of sexual assault and sexual abuse. So in general, I think that that's sort of the same across the board. But I think we have seen more people with, more like just difficult, like living is traumatic for them,
Sure.
Yeah. Limited social support. It's frequent for patients that are trans, non-binary to have fallouts with their families and have parents that are not supportive. And have trouble graduating high school, have trouble getting a job, and then a lot of depression, anxiety, and have trouble, continuing to be gainfully employed. And it's expensive to live. Like
Right.
it's really, it's just crazy how expensive it is.
I mean, Amanda, Kate, you were saying the families who have come here to
Yeah.
Connecticut, that's an eye opener in terms of rent or
yeah.
mortgage
Yeah.
costs. In
It's
terms
not a
of,
cheap state to
Absolutely.
live in.
Yeah, in terms
We're,
of the-
we're I think the 9th most expensive state to live in or something. So.
Yeah, so it's a really hard decision on the part of these families who realize, okay, if I'm going to keep my kids safe,
Yeah.
I might need to give up my job,
Yeah.
sell my house,
Yeah.
and move to someplace new.
Yeah.
that maybe I,
I
can't
mean, look
afford.
at the people coming up from southern countries, like trying to save their children from
Right.
like all the violence, and moving a state is difficult as well, like without your social support system. So other forms of trauma include medical trauma, like a lot of patients.
How could I forget that?
Yeah, a lot of patients might be thinking about transitioning or understanding that they're trans and not knowing how to go about accessing gender affirming care, and come to a point with their current providers where they're just not accessing the care that they need. And we have to overcome that as well, the mistrust of the medical community. And we have to, a lot of times, we don't even examine patients the first time they come to meet us.
Just have that
We
sit
just,
down.
we're just like, what do you need and how can I help you achieve what it is that you want to do?
Yeah, I would say as far as medical trauma goes as well, just having uninformed providers. I mean, so many patients will be so relieved when we ask them certain questions because they'll be like, oh my gosh, no one's ever asked me that. Or I've had to explain 15 times why I don't need contraception or whatever, and it's a relief, I think, for a lot of patients to come to a space where they're like, oh, okay, like this person gets it. When they're talking about barriers, they're not necessarily saying condoms. They're saying like, oh, do you use barriers? Do you try Laurels? Like all these different options for them because maybe they're, a sapphic person or whatever. So
And Laurels are.
Oh, Laurels are barrier underwear that you can use for sort of protection. Typically for people that are assigned female at birth that they can wear, and they come in all different kind of shapes and cuts. And it's like a grown-up dental dam, I guess.
Yeah.
And-
You don't have to hold it in place. You just wait.
yeah, you
Just
just put them
wear it?
on. Yeah.
Wow.
Yeah.
Super cool. Never heard of those. I'll be doing research.
This is
later.
not sponsored by Laurels, but we would love to be sponsored by Laurels.
Exactly. Please send all inquiries to crmtranscat@gmail.com. This sort of caring, trauma-informed care. Give me a percentage. How widespread is this in your business?
How? What do you mean? Like, how many patients do we see?
No. How many providers do you, in your estimation, are providing this kind of care?
Oh my gosh.
As opposed to the sort of rigorous time frame in, out, gone.
A dreadfully small amount.
I think you can name them, right? Like you can say it's the anchors and it's the, Middlesex Health and it's the, there's all these certain groups that we all know of. But what we have found in the last couple of years, like really opening up our practice and making these relationships with a lot of these, gender clinics and things like that, is that it's tough, especially in the field of gynecology. There's not a lot of us because you have to remember that a lot of gynecology is not just gynecology. It's obstetric gynecology.
Okay.
And in a practice that is obstetrics and gynecology, obstetrics like kind of, I hate this term, but trumps all. And I know, sorry, I
triggered
should
me.
trigger warning.
Sorry, we didn't ask if that was going to be triggering Claire. She needs coffee.
Actually not trauma informed to me, so I apologize. No, but truly, it's tough for these patients because, when you're in that practice, you have a lot more pregnant patients than you do not. And so the sort of specialization is not there. So we're very lucky in that because we do not do obstetrics, we can really focus on the gynecologic part. So
I think of all fields of medicine, OBGYN practices more trauma-informed care than a GI doctor or a lung doctor. But we all should be asking permission before we touch patients.
There you go.
We should, when we have, in our particular field, we do what we're calling sensitive exams. So pelvic, chest exams. But your body should be autonomous, and we should always be asking permission before we touch each other's
And
bodies.
we do pretty rigorous, again, while the patient is still dressed. This is what we recommend. This exam looks like an assessment of your chest tissue. It looks like an assessment of the perineum and, the vulva and the external structures, depending on what terms the person, prefers. And then we explain what we're going to do inside and why we're going to do it. And, I always like to tell people, don't worry, I'm not sticking anything in your butt. So, all of these things so that people are fully informed, and then they can say, this part sounds okay, this part I want to skip, and really taking that moment to do that. And I think I do agree with you. I think OBGYN, we are and need to be more trauma informed and more really consistently checking in for consent throughout the exam multiple times. Yeah.
My first mammogram, I remember being very pleasantly surprised about that. There's this constant readjusting of my body, and every time that prefaced, okay, I'm gonna do this now. I'm gonna turn you this way. Is that okay? And it was like, oh, okay, I appreciate that. 'Cause the first time out, I didn't know what to expect.
It makes you feel safe.
Yeah.
Yeah.
And somebody who's perhaps aware that a trans person is maybe a little more sensitive about body parts.
Absolutely,
and the exposure of them to other people.
For cis people, cis women, there's anxiety regarding the GYN exam and the pelvic exam and the pap smear. And young women come in, a lot of the times their eyes are huge and they're 15 or 16 and they need contraception. And we're like, I don't even need to go near your vagina.
Keep your pants on.
Yeah, like we're good. And that's the first thing I say. Like literally, I don't think you need an exam today. Now let's put that anxiety to the side and let's talk about why you're here. But I think Amanda and I actually, part of our mission is to educate providers on how to practice specifically gender inclusive care. Gender inclusive care is every person, because every person has some sort of gender identity, whether it's non-binary, trans, whatever, we're here for it. We gave a talk recently to the Greater New Haven OBGYN Society talking about gender-informed care, gender-affirming care, and we, of course, throwing in trauma-informed care there too.
Right. What does gynecology look like for trans people? Because I think, you said that the percentage of providers out there who are practicing informed care is frighteningly low. But what are the things that need to be known about that the average person might not know?
I think the most important thing is cancer screening.
Absolutely.
The most important thing. That's the number one thing, is that if you have a type of anatomy, for example, if you have a cervix, which is the lower part of the uterus that's at the top of the vagina in AFAB people, that needs cancer screening. And that starts at 21 years old and then every 3 to 5 years, depending on risk factors and previous screening. If you have a prostate, you need prostate cancer screening. So even if you've had a vaginoplasty, prostates are not typically removed during that surgery. So you need to know that you still need to get prostate cancer screening. If you have had top surgery, if you have had masculinization top surgery, typically you still have breast tissue left there, and you should still have mammograms. And that's an important conversation.
And at least a yearly assessment and an understanding that you do still need that, because we sometimes have patients come in and say, oh, no, I've had top surgery. And we'll say, well, you can still have changes there. So
I can see where that would be traumatic for a transmasculine person in that this was something you chose to do in order to closer approximate your gender identity, to then be in a situation where it feels like you're being treated what your old body used to be. I've got to imagine that's hard.
Here's the thing. Our job is to educate people. This is what I tell them. I say, this is what we recommend. My job is to keep you safe. And part of that safety is screening. And this is the screening we recommend. And then we allow that person to be an adult and they make the decisions that they're comfortable with. And I think that for a lot of providers, that can be very uncomfortable,
Sure.
right? So I know a lot of providers who will be like, well, I don't want to see this patient anymore because they don't want to do, any of their care. And the problem is with LGBTQIA plus people, that they get marginalized then, and then they're remote from care. And then that person who made them feel guilty or bad about a choice that they made about their bodies is now keeping them from getting any health care. And so it's really important that we remember that people can make decisions about their own bodies. If we really believe in like autonomy and informed consent, then like our only job is to educate and then allow that person to make those decisions for themselves. So yes, I think it could be very traumatic for the person to feel like they were forced to do it. I like to think that we tell people, this is what we recommend and you're going to do what works for you.
Yeah.
I got goosebumps when you just said that. Like that is like the crux of our practice.
Yeah.
like you come in for a consultation. I will tell you what is safe, what is reasonable, what the data shows, and then you leave and come back. We will reconsult. We will talk about things that have changed, but I am not going to fire you as a patient because you didn't get a mammogram, for example. And truthfully, it's all about risk. So if you have top surgery, masculinizing top surgery, your chance of getting breast cancer is much less if you're on testosterone and you had your ovaries removed than a person that has natal or breast tissue that they were born with that still has their ovaries, much less. Is it quite that of a assigned male at birth person that continues on their testosterone that is in natural producing testosterone? Probably not quite that low, but definitely much lower than a cis woman that's been walking around.
Yeah,
with her
and a good
ovaries.
reminder that people that are cisgendered males still get breast cancer. Yeah.
Yep.
Which is, again, not something that
We talk about a
people
lot.
think. Yeah.
Yeah.
Talk a little bit about bottom surgery or not bottom surgery in terms of your practice, because that we were talking a bit about top surgery and how that changes your odds of cancer. But some people in their transitions are able to have bottom surgery. Some are not. And for those who are not, getting the sort of treatment for your old gender identity can be really triggering. I remember that period between when I came out and started transitioning, started on hormones, until I was able to get bottom surgery. I was even more dysphoric about what was going on down below than ever before, and it got pretty bad. So the courage that it takes to come out and say, "This is my gender," and then you're back in the stirrups. Or
Well, so I will just start by saying I hate the word stirrups.
I know.
We are
Flipping
not
foot
horseback
holders.
riding.
Yes.
I say foot holders. And also part of a trauma-informed GYN exam is, are you comfortable using the foot holders? Or would you like to lay like a frog? I literally demonstrate to my patients. You can do this with your legs. You can hold your legs like this, or you can use the foot holder. So
then why
no
did
forced stirrups.
Why did my doctor ask me to whinny? 'Cause it seems. Now especially. I thought
not
it was
trauma
I
informed
thought at
care.
the
You've got some
time.
questions.
I don't know why this is helping. I don't think it is.
That's lovely. I love that.
Awkward.
We're both like former
girls.
horse girls, so we really appreciate that.
Okay, so no on stirrups.
So, but I mean, and again, that's probably like a little tiny bit of it, but it's stuff like that. It's language like that, and it's sort of forced. Like you go in a room and the stirrups, quote unquote, are out. That's like scary. That's our seats look like a seat, and then I say, this is what it looks like to put your foot here. This is what it looks like to hold your legs in this way, and which would you prefer? Because guess what? It's a little bit trickier. It's a little bit more challenging as a healthcare provider to not have someone use the foot holders, but that's on me. Like I can figure it out. I am an educated lady. I got this, So like, let's make you comfortable. So that is one piece, but also starting first and foremost by asking the patient, saying, we're going to talk about anatomical things with your body and what are your preferred terms? Because that is something that can be helpful because if someone, maybe doesn't prefer the word vulva or vagina, they're very sort of feminine related, right? So maybe they say front hole or
manhole.
Yeah.
External or internal.
Yeah. I had someone call it their bubba. And that was lovely. And also I had to keep telling myself to call it a bubba. And I was like, okay, I got this. A bubba.
Yeah. And, some patients want to refer to them in what we traditionally recognize as masculine terms. Like I have patients that have wanted to refer to their enlarged clitoris after they've been on testosterone as their penis.
Okay.
And I just want to make sure that I line up with whatever you're comfortable with.
In our anatomy, we have anatomy posters in every room, and Dr. Rostkowski and I, in our room specifically, make sure that they say human anatomy and not female anatomy because a lot of them, they come that way. We have to do a lot of sort of doctoring, as they say, to kind of like zhuzh it up and make it inclusive.
Yeah, inclusive.
And that can be really helpful because patients sometimes, again, when they're removed from that association with their lower half, they're kind of, but they need to tell us that they're having an itch somewhere. It's really helpful for them to be able to kind of point and say, it's kind of like right here. Yeah, exactly. And so I think that is something that is helpful.
Yeah, I think that when we recently rebranded our practice and we chose the name Comprehensive Gynecology because we had to be able to market ourselves as what we were. We're gynecologists, but we didn't want to be like women's center or women's clinic or anything like that. We wanted to make sure like gynecology should really encompass any patient that has a vagina, whether it's a neovagina after a vaginoplasty or a uterus, cervix, tubes, ovaries that need care. One of the other things that we do is we recognize that for any person, having an invasive pelvic exam can be difficult for many different reasons. Sure. So we do offer patients exams under anesthesia. If you need to have an exam for a particular reason, for surgical planning, for biopsies, for even just a simple pap smear, we have the ability to do that for you if that is something that you need. We offer patients the ability to self-pap. I go over the instruments, the small brushes, because all what we need is a very small sample of the cells around the cervix, and we also test it for HPV or human papillomavirus.
And it's a cul-de-sac. So I always tell people, like, if you push that little brush in, you're probably going to hit the cervix.
Yep, it's a dead end. There's nothing's coming out of the other side. I show them the different brushes that they could use. I show them what it would look like if they were to insert it. You just insert it till it doesn't go anymore. You squish it around and pop it in the vial. I mean, 95% of the time, patients are able to get an adequate sample from that.
And a good amount of patients, actually, sometimes I find are just like, nah, I don't even want to touch it.
Yeah.
You go ahead. Yeah. Like, okay.
Yeah. But
it's important, too, to remember that it's not just, we talk about, cervical cancer screening, let's say. And if someone has, bottom surgery, which many times for a masculine person is recognized as like a hysterectomy, let's say, they may still have an ovary that we should probably keep an eye on. They may still have, and actually we sort of recommend that they keep at least one ovary.
Yeah. We'll get back to that in a second.
But
I want to hear about that.
And then there's other parts. There is still a vagina. There is still, a urethra and a vulva, whether they, call it different terms or not. And there's things that can go on. There is such thing as vulvar cancer, and we've seen it in our practice. There are such, conditions that people will sometimes have after they've been on T for a long time, where they have atrophy or something called DIV, desquamative inflammatory vaginitis, like all these things that can still cause you problems. And it's really nice to have a place where you can still go and be seen for that, because some people think, oh, well, I don't need anything. But guess what? Like, you might still need something. And we're there for that.
I think, Claire, when you were talking about bottom surgery, we in our practice have started seeing a lot of trans feminine patients that have had vaginoplasties, because right now in Connecticut, there's nobody really doing them. Patients are having to go to New York, they're having to go to California, some patients to Pennsylvania to have these surgeries, and then they're coming back home and having complications. They're having bleeding, they're having discomfort with penetration, they're having UTIs. And so we made it a point to learn more about those procedures and to help those patients locally close to them. Even then, patients are coming from New London. They're coming from Massachusetts. They're coming from Rhode Island to see us because there's nobody really around.
Yeah.
As far as masculinizing bottom surgery, there's something called a metoidioplasty, where after you've taken testosterone, it can make the clitoris enlarge. And a a type of surgeon, either a urologist or a plastic surgeon, or the two of them in conjunction, can go in and sort of loosen the tissue, because the clitoris is quite a big organ. The little like sort of bean that you think of, that you see, it's actually quite larger than that. It's sort of like a wishbone shape, and it comes out to the sides. Yeah, it's really cool. So you can sort of loosen up those tissues to create an elongated phallus structure. And then there's other surgeries like a phalloplasty, where you can actually do grafts of much larger tissue to make a much more phallic or penile-like structure. And they're not super functional as far as erections go. You need to have a prosthesis that you can pump up in order to have an erection. But functionally, as far as being able to easily stand while urinating, which can be very gender affirming for patients, that is able to be done. In our practice, we haven't seen patients with those procedures yet. I think they're much less popular right now. I think the techniques are constantly changing, but lots of patients have vaginoplasties, and we're happy to see them.
I did go to New Hope, Pennsylvania, to Dr. McGinn. Somebody who had been there about a year before me, I know, did have trouble dilating. There was a lot of discomfort. I forget exactly what was going on. And it seemed to me, wow, that whatever that is, an 8-hour car ride is a lot when you're concerned that something might be wrong. And the folks in New Hope are great. You could get them on the phone. They would, they'd be happy to ask you questions. But there's something to be said for being able to drive half an hour and be at your care provider in terms of just being reassured.
Even just reassurance, exactly.
And, I think the other thing is we want to foster a relationship of honesty with our patients. And so I would be remiss if I didn't say to them, sometimes I'll look and say, you know what? I'm not actually sure what we're dealing with here, but here's my plan of action. We're going to try this. We're going to test you for this, and you're going to tell me if this is better or worse, And I think that is also because we don't know everything, right? There's no way we could possibly see every scenario. And so I think even though we're in a little oasis in a desert, we do the best that we can do, even if we don't know, to kind of just help people.
I think that can be really frustrating for patients and healthcare consumers as we talk about them these days, that we don't know everything. Even the field of medicine doesn't know everything. Like one of my other specializations is pelvic pain and endometriosis. And sometimes I can't figure out why a patient is having pain. And I'm like, 10, 15 years from now, we might have a test to be like, oh, you have condition XYZ that we literally just don't know about right now.
Folks in the medical field have been set up traditionally to be the gatekeepers, to be the authority. And when you hear that, I'm not sure what's going on here, that can be triggering. Or when, to pull it back to the language, Amanda, Kayte, that you were talking about, if I'm sitting there with somebody who is using exclusive language, it's very likely that I'm going to take that as, okay, this gatekeeper says you're not welcome here. So
Absolutely.
Just keep it to yourself. I don't know what the hell's going on, but let's just keep it to yourself, go home.
That hurts
Try
my
somewhere
heart,
else,
to be honest. But I
get
that. Yeah, I do get that. And I also want to just throw this out there for patients. We have so much at our fingertips now, right? You can online take every course at Harvard or, whatever. So people are well informed. And so we will see people with their third and fourth, presentation to a gynecologist being like, I really think I have this. All these people told me no. And I'm like, you know what? You've been in your body for, 44 years. You know your body better than anyone. So if you are telling me that there's something not right, let's try to figure it out, I think we have to take some of the ego out of medicine. And that is, a huge part of what we do, is we recognize that probably a lot of our patients know what's best for themselves. And when they come in and they tell us, I really think it might be this. Certainly it's our job to rule out all different, things. But I think that's something that sort of sets us apart too. We're never going to be like, well, your test was negative, so you're fine. That's, that's not helpful.
On
right?
your way.
Yeah,
exactly. So
I'm the best. Yeah. Congratulations.
Yep. That's $400.
Yes.
Just back to what Amanda Kayte was mentioning about ovarian preservation during gender-affirming hysterectomy. We all know the political climate in this country has gotten scary for trans folks, for people with uteruses, for lots of us. So 5 years ago, when we first saw our first trans patient and we were like, these people need help before the courts were stacked, let's say.
Yeah.
Because that's really where things got scary. And a patient came in and said, listen, my uterus is causing me dysphoria. I want it out of my body. I would say, okay, we're in there. Let's take your ovaries out too. Your ovaries, as long as you are, one, planning on being on testosterone forever, planning on not moving to a place where testosterone access would be questionable for you, do not plan on carrying a pregnancy or being the genetic parent to a child, we can take your ovaries out. There's no need to keep them. They're not going to do anything for you. But now I cannot guarantee people are going to be able to access testosterone. I just can't. In this country, in the United States of America, I cannot guarantee that is going to be a right that they are going to have. So I'm saying, maybe you should consider keeping an ovary. The reason is that human bodies need some sort of sex hormone. And by sex hormone, we're talking about estrogen or testosterone.
Right.
You need it to keep your brain healthy, your heart healthy, your bones healthy. You might have heard of osteoporosis, which is a condition that postmenopausal patients get when their estrogen levels go down. Your bones, your body doesn't use calcium in the right way, and it starts taking calcium out of your bones, and your bones can get thin, and you can break a hip. You can break your pelvis. And those are extremely morbid conditions, meaning they have a lot of complications.
I was going to say, and high mortality rates.
High mortality
for a
too.
lot of, patients with osteoporosis that are, assumed female at birth of a certain age, and really a certain, if you're Caucasian and if you are small, we have this focus in our society also on size, right? So
we could talk a whole hour about sizism.
Please. But yeah, if you are, the preferred size, then you have such a higher rate, risk of, dying literally. So it's important that we think of all those impacts, the hormonal impacts of if someone lost access to hormones.
Yeah. So I say to patients, if we take both of your ovaries and for whatever reason you lose access to testosterone, I would recommend you then take estrogen to help protect your physical body. Right. And recently I had a conversation with the patient, and they were like, I would rather take exogenous or take extra hormones, take oral hormones or a hormone patch than know that this ovary is going to be making estrogen inside me. So I want them out. Okay. I said, great.
Let's do that.
I will happily do that. Yep. Not a problem.
Informed consent.
Consent. As long as you understand, if I think it is safe and reasonable, I will do my best to do it for you.
Yeah.
Because when we're talking about the surgery itself, and by the surgery, I mean a hysterectomy. Total hysterectomy means the uterus and the cervix are removed. And then there's a bilateral salpingo-oophorectomy, which means both of the fallopian tubes and ovaries are removed. So typically, gender-affirming hysterectomy is just uterus and cervix, and then the fallopian tubes, and then we talk about the ovaries. The surgery itself is no longer or no more complicated if we take the ovaries or leave the ovaries. It's just making an incision, 2 inches to the left or to the right.
One of the things you were, as I listened to both of you speaking about these various procedures, is it took me back to the Supreme Court discussing the overturning of Roe v. Wade and the utter scorn and disdain that was shown for words that might be inclusive. So instead of saying the mother, you'd say the birthing parent.
Yeah.
And it was just so blatant that, and it seems to me that that's exactly what we're talking about here, is that I'm sorry to make you cishet person, cishet doctor, I'm sorry to make you uncomfortable, but my body doesn't conform to this non-existent binary.
Right.
And could we please approach it as if I actually existed?
Yeah.
And use words that aren't going to make me feel like I'm out of here. I'm going home.
It's so infuriating that being inclusionary makes some people feel excluded. It's so bizarre.
Yeah. And so, that was a really conscious choice that we made again as we sort of started this rebrand of the practice, because we wanted to make sure that we were inclusive. And, as a parent to a trans kid, I have Protect Trans Kids stickers, on my laptop and in my room and art and things like that. And I've had patients that are, per their own words, cisgendered, heterosexual, and they'll come in and be like, well, what does that mean? And I'll say, well, what does it mean to you? And they'll be like, oh, so you're going to do sex surgeries on children? And I'll be like, no, that's actually not what that means. What it means is I love and respect children and their rights to identify how they want to identify. And I'm going to support that. And as a trans parent, this is my right. And if you'd like to talk about it further, you let me know. But for every one person we have for that, we have 99 people who are like, I love your stickers. What a cool poster. Even, again, like allies. Like we see these heterosexual, cisgendered people that are like, yeah, I love your rainbow. Like, I have rainbow sneakers. I love your rainbow sneakers. I'm like, yeah.
Allyship is so crucial.
Yep.
And I think the trend, and I say that in quotes, about putting your pronouns after your name on your email signature, I love that. I think it's fantastic. And sometimes I've seen there sort of be a backlash against it a little bit. And I think it's just such an easy thing to do, to let somebody else know that they're safe sharing their pronouns with you. And everybody has a pronoun sticker on their computer so that it's very obvious. We have a check-in sheet where patients can identify their pronouns so that they don't have to verbally say it if they're uncomfortable. And it's right at the banner or the header of their chart. It says their legal name, which sometimes does not match the name that they use currently, but that's the name that is on their insurance card. So it's the name that has to be associated with their chart, the name that they are using, and their pronouns.
Yeah. And it starts at the front door. I mean, truly, we work really hard to make sure that all of our staff are on board. So there is not a person in our office who's going to say like, well, I don't believe in trans care. Because if they did, they would not work at our office. So, we make sure that our front desk staff knows that if a man named Robert calls and says he needs a GYN exam, he does. And that's the end of it. You're not saying we don't do that here. You're not, and
which happens. It happens all the time. Patients call gynecologist's office and they're like, hey, I'm Joe, or I don't know what's a more masculine sounding name.
Axel.
Yeah. Axel. That's a cute name.
I know, isn't it cute?
I do like that.
I want to meet Axel now.
Robert was a good one. Like, hi, I'm, patients all the time, they tell us that they called and they said, hey, I'm Robert, I need a GYN exam. And they're like, why? Or we don't do that.
Or they're registered as their, birth name, let's say, or their dead name. And then they come in and looking all masculine and bald with like a cool beard. And they're like, no, this is a gynecologist office. And they will like turn them away at the desk. Like that blows my mind.
And you couple that with some of the basic niceties that were drilled into us as kids, where if you're in that position in the reception in your office, you'd better be saying sir and ma'am. You better be polite. Well, please don't do that to me.
Right.
Please do, because if you are just looking at me and just listening to me, I'm going to say you're 85% likely to say yes, sir.
And what about our NBs? What about our non-binary patients who are like, I'm not either of those?
So, and it's as simple as adding that form, that column on your form to tell us your pronouns. It's that simple to say, let go of that. That is an outdated notion. It worked fine for a couple of centuries. But now there's no reason for you to either sir or ma'am me. You can still make me feel welcome.
I was going to say, and guess what? It's not going to be perfect, right? So there are going to be times where someone makes a mistake and they might say, like, I tend to be very like flamboyant in my visits, and I'll be like, yes, queen. And then I'll be like, and sir, because I'll recall that person does not identify as queen, and so you fix it and you move on and I think the most important thing is you acknowledge it, you fix it, and that's it. And you don't make them feel bad that you made a mistake.
You don't turn it into it's not about you.
Right,
You
exactly.
say, oh, sorry. Yep, sir.
And I think we all need to practice. Like it's the practice of medicine, right?
Yeah.
Like we're all not going to, even if you decide tomorrow that you are going to be the most inclusive gender fighter like in the world, it's not going to be easy. Even the kids these days, man, they are so open and they are so themselves. And I think about, so I am a cisgender female. My pronouns are she, her, and I am a lesbian. I have a wife. We have two beautiful, currently male children that, whatever they are, they're going to be, and we will love them forever. But even me, who I feel am pretty like, whatever, you do you, just be safe. I'm learning about all of these other gender identities, like even just male, female, trans female, trans feminine, trans masculine, non-binary, agender, like, and there's other ones too. And the label doesn't matter.
Right.
What matters to me is what healthcare do you need?
Right.
And how would you like to be addressed?
Yeah. And how would you like to be addressed?
There you go.
Yeah. Exactly. But when we're talking about sexual health, which is another big part of our practice, is in medical school, and I graduated, I'm going to date myself a little bit. I graduated medical school in 2010, and then we weren't learning about trans care at all. I had zero education on trans care, zero. And our sexual health education was you ask a patient, do you have sex with men, with women, or with both?
And
that was it.
That was your choices.
That was your full sexual history.
Yeah.
And you can't do that anymore.
Right.
It's not, and it's not even informative. My questions are, tell me about the partners that you have. Do they make sperm? That's like really my number one question. Like, do you need contraception? Do you have penetrative sex? Do you put anything inside of you? What areas do you use? And do I need to screen those for sexually transmitted infections?
Do you use barriers? Do you need contraception? Because honestly, sometimes people will say, well, my partner doesn't make sperm. I'm like, oh, well, is that your only partner? And their other partner does make sperm. You know, so it's like we can't make these assumptions. We leave everything open-ended. And I think allowing patients to share that stuff really helps them, get the comprehensive care that they need. Because yes, again, I said patients know what they need a lot of times, but sometimes they don't. Sometimes we'll say like, hey, you know what? You should probably be tested for, this. And they're like, oh, really? And I'm like, yeah.
Or like you're polyamorous, you have multiple partners, and then those partners have multiple partners.
Right.
You maybe should be taking PrEP. Like maybe we should talk about that. And we want to. We want to give you your options.
Yeah. I love when patients come in and they tell me something like, they'll be like, well, I was bottoming in my back hole. And I'm like, tell me more. Only because, not in a creepy way, but only because.
Not in a creepy way.
Not in a creepy way.
That's good. Well, that's good. I'm very glad to hear that.
Because it helps me understand, like, oh my gosh, I should be asking more of my patients, about that, or they'll say like, oh, they are romantic, but homosexual or whatever. And I'm like, what does that mean? They're like, oh, well, I don't like date, but like I do have sex, and I only have sex with people that are like femme. And I'm just like, it's complex, right? And so again, the label part doesn't matter, but it's the base info. Like, what do we need?
Right.
Because there are people we know for centuries that have identified as heterosexual that have lots of gay sex.
Yeah,
totally.
Well, that was the whole problem at the beginning of the AIDS crisis, is that things were targeted to the gay community and completely disregarding the fact that, as you say, there are plenty of men who have sex with men who would never identify themselves as gay.
And who are then having sex with women who are getting HIV.
Yeah, right. Let's take care of the practical first. Where can folks get in touch with you guys?
Great question.
Thank you.
So you can Google Comprehensive Gynecology of Connecticut. We are in Hamden. It's my radio
60
voice.
Washington Ave.
Yeah, we're
Thank
60
you.
Washington Avenue.
And we're suites 201 and 206.
Yeah,
so
we're big.
we make it extra complicated.
We're spread out.
In that Dr. Rostkowski's sort of area is in 201, and I'm over in 206.
We are part of a larger organization throughout the state of Connecticut called Women's Health Connecticut. So we're a division of that. So don't be off-put by the women's in the title.
We're the comprehensive.
Yeah, we're the comprehensive part. If you need us, we will take care of the bottom parts you have.
And I was going to say, we are a larger practice too.
Our practice right now
Many of
is
us
made
are.
up of myself, Amanda Kayte, another nurse midwife, Shoshana Zaks, nurse practitioner, Tracy Gahuli, and then we have two other physicians in our practice. We have Dr. Emily Fine and Dr. Ayanna Lyles.
For each of you, as a final question.
Is it over already?
I'm sorry.
I wanted to keep going.
I know.
Okay,
Can we
go
just,
ahead.
We'll turn the mics off
I
and
feel
we'll
like
just
there's
keep
like 12
talking
other
for a
things I
while.
was planning to say, but that's fine.
Do. Jump in. Is there something I forgot to ask? That's probably, I should ask that.
Well, Claire, that's a great question or a great statement, because at the end of every intake, we say that. We say, is there anything that I didn't ask about that you think is important for me to know as your healthcare provider? And sometimes patients are like, oh, my father committed suicide. And I'm like, oh, well, I mean, that wouldn't have come up. So thanks for telling me. Like, we do depression anxiety screen or just something that I just didn't think to ask that they think is important.
Sure. Yeah, absolutely. And again, that's that part of where it can be really scary for a healthcare provider who's only allowed 10 minutes to do something like that.
Right.
But at that point, we're entirely their provider. And when I see the next patient, and if I'm a little bit behind, I always say, thank you so much for your patience. I never apologize really, because I'm not really sorry.
Yeah.
Because I gave that person what they needed, and now I'm here with you, and I'm going to give you the same.
So last question then. Why does this matter? Maybe, maybe a particularly illustrative case that you had, but all of these things we've been talking about, trauma-informed care and awareness of the fact that there are many different gender identities and sexualities, and those overlap, creating a really complex environment. And yet you're saying you are two of the very few people in our state who are practicing this way. So for each of you, sell me on this. Why is this important?
When you meet a patient for the first time, your eyes have never met, and you open the door and you walk into the room and you see their body language. You see them not really being able to make eye contact. You see them, their hands are in their lap, their body is all tense. Yeah. And they are really terrified of what this visit is going to be like for them. And then by the end of the visit, they're much more relaxed. They're looking you in the eye. They're smiling. You made a connection. They feel comfortable. It's like one of the best feelings in the world. And then when you go on a gender journey with them and they're there, especially specifically for me, I get a lot of referrals for gender-affirming hysterectomy. So probably 2 to 3 times a day, I have a patient as a consultation for a gender-affirming hysterectomy. And when we go through the steps, when we talk about what surgery is going to be like, what recovery is going to be like, what sex is going to be like after if they use their vagina for sex, and then we do the surgery, and then I'm at their final visit and I go, this is it. This is our last visit, and thanks for letting me take care of you. And they just the smiles, the joy. And it was so easy, like truthfully, it was so easy for me to do. And the change that it made in that person's life is just like, there's no more fulfilling thing in the world, really. And it is part of our goal to educate gynecologists. We have medical students come through our office. I am on clinical faculty at Yale. I'm educating residents, and I am gently beating it over their heads about how important it is to make sure your discharge instructions, that we have a lot of templates, and a lot of the templates say women and a lot of the templates say female, and we're working on updating those so the default templates are not she, her, women. So we're making grounds, but definitely that patient that I see, like, I think we can all just like feel that anxiety.
Oh yeah.
Yeah. And then just being like, it's okay. Here, you're safe. It's worth it. And every person deserves that. I'm sure we've all had interactions with a doctor where we're like, well, that sucked. And there are going to be some visits that are shorter and there are going to be some visits that are longer, but everybody should feel cared for no matter what.
So truthfully, I became a midwife because I had a really wonderful care experience. And I, prior to that, was a closeted queer kid who every time I tried to come out and say, I just made out with this girl, my parents would say like, oh, you haven't met the right boy, and, all that kind of thing. And so I never felt uncomfortable. I had some really like sort of traumatic experiences. And so when I finally had an experience where the midwife sat with me and said like, do you have a history of trauma? Are you comfortable with, this part of the exam? I mean, I cried, and I thought, oh my God, there's something better out there and I could do this. And so that's why I became a midwife. And when I get to sit with patients and, offer them alternative options and let them know that, they're safe no matter what they decide, and they're not disappointing me, and they can still come back, and, all of those things. When a patient cries with me, it means so much, because it means that they feel safe and they feel like they can share. And I look back at myself as a little girl, as a mom of like a trans kiddo, like, and I'm just like, I want that for my kids. I want that for every patient. I want everyone to feel safe. We all deserve to feel safe. And so at the end of the day, affirming care, inclusive care, trauma-informed care, it matters because we're people. We're people, and it costs nothing to be compassionate and kind, and that's it. I just want to leave people even better than when they came in. A shout out to Janet Spinner, retired
Janet
midwife.
Spinner?
I know she was the sweetest sweet angel. I know. She did infer that I was fat when I was trying to conceive,
well,
so that does knock down a couple points, but that's okay. We still love her. We still love her.
I don't know if Janet would ever hear this, but I have a memory of doing a delivery with Janet, and she was so excited because it was just like the most beautiful vibe in the room. She kissed me right on the cheek. She was just like, oh, and just like a big fat one right on my cheek.
Yeah, she is a very special person. And anyway,
she practices gender affirming care for sure. I've seen patients recently because she retired, I think, and a patient recently was like,
Yeah.
I saw her.
yeah.
Oh.
So anyway,
Shout out to Janet Spinner out there.
and for anyone who wants to get into medicine, there is a niche for you if you care. Like if you truly, truly care, you might be in a place, you might be in a practice where you're feeling like I'm not able to do what I need to do. And guess what? There is a place for you. And if there's not, you can make it for yourself. And
We
make it
need
for
more
patients.
representation in medicine. We need more trans people.
Yep.
We need more queer people.
Sure.
Bring it.
But as someone who was 33 years in the classroom, the kids who were expected and expecting to go into the medical field, those weren't the qualities that were being assessed. Are you really good at science and math? Do you have the drive to get through all of that schooling and prep? And, are you excellent? There was never any point where they said, well, are you
A good
caring?
person?
Are you compassionate?
Yeah.
Yeah.
Can you feel Amanda, you were saying the tension of that patient when you walk in the room.
Yep.
Can you feel that and react in a way that is loving?
And I don't know that that's a skill that you can teach. I truly don't. And I'm sure we've all been there. But, there are some providers that are brilliant, wonderful, providers, but that don't have that bedside manner, right? And so I think that if you have that, if you in your heart and soul just really want to care for people, you can do it.
I love you both. Thank you so much for being here. Amanda, jump in.
Sorry, there's just one more thing that I have to say. Gender affirming care is not a new thing. It has been around for a very long time when we talk about cosmetics, which even back in Egypt times, like long, charcoal, makeup, mascara, that's gender affirming. When we talk about hormone replacement therapy for patients in menopause, cisgender women, that's
Cisgendered men who are
want testosterone,
exactly.
low libido.
Yeah.
Viagra can be seen as gender affirming.
That's the whole point of Viagra, as I understand it.
Exactly. And so this is not a new thing. So cisgender people feel fine receiving gender affirming care. It's just when it's outside of what they consider normal, quote unquote, is when it's a problem for them. So everybody deserves gender affirming care no matter what the hell your gender is.
And that's it for season 2, folks. I've put a link in the show notes to the Comprehensive Gynecology of Connecticut website. If you're looking for the types of health care that we discussed in this episode, reach out and tell them Transqat sent you. If you've enjoyed this conversation, please consider revisiting episode 18, where I spoke with Stefan Simonovich about trauma-informed mental health care. I've also included a link to the 3 is a Magic Number video. Consider it your summer reading assignment. Transqat will be on hiatus for July and August. We'll be back in September with season 3, all new conversations. My thanks to all the guests who have joined me in season 2. I learned something from each and every one of you, and I'm grateful for your time and your willingness to share. I am working on my annual Pride Extravaganza episodes. New Haven, Connecticut, and Burlington, Vermont are in September, so I haven't decided yet whether I'll release half the material over the summer or save it all for a 2-part opener in season 3. Either way, keep an eye on your feed for updates. This has been Transqat. I am Clare McCarthy. Thank you for listening. Enjoy the summer, and let's talk soon.
This is Sadie McCarthy. I'm Claire's niece.
And you've just been listening to Transqat. It is made by one of my favorite people in the world, Clare McCarthy.
Transqat is a production of Transqat Enterprises, LLC.
Copyright 2023, all rights reserved.
Join us on the web at transqat.com.
That's TRANSQAT.com.
QAT.com.
QAT.com.
There you'll find links to Transqat, the blog,
writing projects,
speaking engagements,
and our PayPal donations page.
Please consider supporting our mission with your monkeys.
Monies.
Your monies. Your monies.
Not monkeys.
Please consider supporting our mission with your monies. Any monkeys will be gratefully received as well.
Follow Transqat on Instagram, Facebook, Twitter, and YouTube.
On TikTok, we are at The Real Transqat.
Want to tell your story on air?
Or ask Claire a question?
What is the deal?
She has all the answers.
Or suggest a guest or topic for an upcoming episode.
Use the contact page at the website
or email her directly at crmtranscat@gmail.com.
crmtranscat@gmail.com.
And thanks for listening.
Thanks for listening.
Thanks for listening.
Thank you for listening.
Thanks for listening.
Thanks for listening. Bye.